Hi, my name is Heidi and I will be presenting my research on the influence of healthcare system on amenable mortality, a configurational approach. On the behalf of our team, Chiara, Josefa, Jonathan, Gary, Adrian, Francesco, and Shannen. The past 50 years have seen health expenditure of countries belong to the OECD constantly increasing, raising concern to the sustainability of financing of healthcare systems. One approach to capture the contribution of healthcare to population health is the concept of amenable mortality, in other words, the premature death from causes that should not occur in the presence of timely and effective healthcare. Measuring healthcare access and quality has become an increasingly important priority in global health policy. This issue is only exacerbated by the current global pandemic. This led to a growing interest in the comparison of health system performance between countries. Several streams of literature coexist to do so. The comparative approach, which for instance give a comparison between social health insurance and tax finance health systems, change on health expenditure and amenable disease, or the typology approach, which would be clustering countries to identify and follow finer variations of healthcare systems. These approaches have several limitations, some of them being methodological. As evidenced in the literature, there is a complex relationship between health system finance and amenable disease. Given the multiple causes of many health outcomes, it remains a challenge to assess the contribution of healthcare to population health. Health system dimensions do not vary much over time. For instance, the GP remuneration, and depends mostly on regulation shocks for which effects can take time to appraise and evaluate. On the other side, typologies of countries based on their health system have been proposed but tends to be fragile when the temporal aspect is integrated. In addition, those approaches did not necessarily capture healthcare quality in its broader aspect. As presented just after, we take here a different approach. Healthcare system influences on amenable disease is contingent on the provision of good quality healthcare, which depends on a broader scope of economic, social, and political factors. Our study investigates the different paths that leads to poorer healthcare quality measured by the extent of amenable mortality within the OECD countries in order to bring some light on the conjoint factors that allow the system to efficiently contribute to national health quality. We focus in particular on the causal conditions that lead OECD's country to poorer health care quality than their OECD counterparts, and the causal conditions that lead OECD's countries to poorer healthcare quality improvement than their OECD counterparts. Our sample was composed of 27 countries with data collected from 1995 to 2014, so 20 years span. We focused on healthcare quality. For this, we used the Health Access Quality Index, capturing 32 causes from which deaths should not occur in the presence of effective care to approximate personal health care access and quality by location and over time. For the empirical strategy, we opted for qualitative comparative analysis in order to identify the causal paths leading to poor health access quality. Country information related to the healthcare system and the economic, social, political environments were coded as our main configurations, using quartile as main thresholds. We use 2010 as reference year to explain the health, access and quality in 2014. Sufficient and necessary conditions, such as associated solution, were examined. Here is a rapid look at the variables included in the study, including 3 dimensions of healthcare system, financing, provision, and regulation, and many other factors more economic, political, or cultural. We will show here the first results of our analysis of the causal condition of OECD poor healthcare quality. Results show that a combination of 4 common conditions lead to poor healthcare quality: poorer GDP, lower urbanization, higher gender inequality index, and poorer total health expenditure. Then several variations are identified leading to country profiles, for instance Greece and Portugal, rather than clusters of countries. Those profiles or archetypes allow us to better understand configuration that may reproduce in other countries and enable more efficient policies. Our analysis suggests that spatial disparity and social orientation play a role when assessing poor quality and access to care. The efficiency and quality of remote hospitals and the health outcome of population in remote areas are often poorer than those in urbanized areas, where access to basic health services and cost of care are 2 critical challenges. Moreover, among the other factors, the retention of health personnel in these areas require high costs and incentives. Technology and telehealth have the potential to lower the healthcare cost and provide better access to remote population in times of need, assuring the provision of primary care. Besides the health status differential across remote and metropolitan population, also socio-economic determinants of health have to be taken into consideration. The results of our analysis builds on the existing evidence related to health disparities in different population groups as highly correlated to socio-economic determinants of health such as income, education, and occupation, environmental exposure, and social environment. Further, it is worth to take into consideration that lifestyle factors related to smoking rate, alcohol consumption, and nutrition education may vary among different socioeconomic groups of population. Therefore, disadvantaged groups of population, such as racial minorities and women, are discriminated against in health. A global effort is required to overcome these inequalities. Indeed, the third Sustainable Development Goals 2030 that promotes health, lives and well-being at all ages set among the others the following 2 targets: the reduction by 1/3 premature mortality from non-communicable disease through prevention and treatment, and promote mental health and well-being, and ensure universal access to sexual and reproductive healthcare services, including for family planning, information and education, and the integration of reproductive health into national strategies and programs. When assessing countries' healthcare system performance, both health capacities and level of qualified inpatient and outpatient workforce have to be assessed. With the growing demand of healthcare services, healthcare systems have to provide standards of quality and equitable access to healthcare services. Among growth, aging society and changing disease patterns are expected to drive greater demand for well-trained health workers in the next 15 years. The Global Strategy on Human Resources for Health, Workforce 2030 reports that shortages can reach up to 9.9 million physician, nurse, and midwife globally by the next decade. The investment in capacity involves the allocation of resources to facilities, equipment, and human resources. The healthcare capacity planning is often challenged by lack of coordination between the different levels of governance. Community and primary care are essential to prevent the development of amenable disease. To strengthen primary healthcare, the proportion of general practitioners among all physicians should be balanced. The right skills and specialization mix of health workers is critical for effective and efficient healthcare delivery. Looking at the current situation, COVID-19 pandemic required a huge expansion of capacity in acute and emergency settings to respond to the large and rapid increase of demand for inpatient care. In this time of emergency, different OECD countries shared flexibilities and repurposing of health workers' roles as common strategy to respond to the emergency. Different healthcare systems hired medical nursing students, foreign-trained healthcare professionals, or retired health professionals to face the shortages of medical workforce. The third dimension that we could discuss is aging and lack of public investment. The drivers of changes in health and social care, as mentioned before, demographic, epidemiological, and risk factor, call for a better integration of health and social care, and strengthening of community care will allow policymakers to answer complex needs of an aging population and at the same time decrease the pressure on the health system, assuring better coordination and improving the health outcomes and patient experience. Public investment in public health prevention have the potential to reduce amenable mortality. The OECD countries of healthcare budget devoted to prevention is still a small fraction of the health spending, less than 3% in average in 2015. Although health promotion and primary prevention measures provide value for money and increase the cost effectiveness of healthcare spendings. Looking at the previous trends, the expenditure in prevention has been affected by the economic crisis and N1H1 pandemic. There is high risk that also the COVID-19 pandemic will challenge improvement and new investment in prevention. Besides international organization promotion, health literacy and public health promotion programs should be part of children and young people education at school to prevent the risk of enhancing the health status differential among different population groups in a scenario of growing socio-economic inequalities. Thank you for listening.